Hello everyone and welcome to the third session in our 7-week Indonesia in Focus academic seminar series. My name is Kate Clayton and I'm a research officer here at Trobe Asia at Trobe University. I'd like to start this event by acknowledging the elders of the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the land on which Trobe University sits. I'd also like to pay my respects to the people both past and present and extend that respect to Indigenous Australians who are present with us today. So welcome to our third seminar, Managing Oral Cancer in Indonesia. I'm delighted to welcome our presenter today, Dr. Elizabeth Fitriana Sari. Elizabeth is a senior lecturer at the Department of Rural Clinical Science at Trobe University based in Bendigo. In today's session, she'll be presenting her research on oral cancer and Indonesia. Thank you, Elizabeth, for joining us today. Before I begin with our discussion, we will have time for some audience questions at the end. So please feel free to pop your questions in the Q&A box during the discussion. And without further ado, I'll hand it over to you, Elizabeth.
Thank you very much, Kate. Hello, everyone. So before we start, I'd like to say thank you to Kate, Diana, and also Matt for inviting me to speak in this webinar event focusing on Indonesia, and also for making this event happen. So today I'm going to discuss or talk about managing oral cancer in Indonesia, as it is aligned with my continuing research since 2015. Right, so there are several strong reasons why I want to do research in my Indonesia, particularly my research in my PhD time, not only because I'm Indonesian originally, but there are way more important reasons why I wanted to do oral cancer research mainly in Indonesia. So first of all, because Indonesia has a huge population. So according to the data taken from May 2022 from Indonesian Statistics Center, Indonesia has 280 million population. This is a huge population. And Indonesian people have been exposed by oral cancer associated risk factors such as smoking, tobacco smoking, paraquat chewing, or we call it menyirih in Indonesia, as well as alcohol drinking. So according to Indonesian Health Department data, 1/3 population, Indonesian population are smokers. And then we have paraquat chewers in many islands, especially in east part of Indonesia, such as West Papua, Maluku, Ternate, Tidore, South Sulawesi, Makassar, and other part in Sulawesi, as well as in Kalimantan, and also in west part of Indonesia, such as North Sumatra. People living there are heavily doing this paraquat chewing for a long time ago. So this paraquat chewing or menyirih has been passed through generation for many, many centuries. So it is already been our culture strongly. And then also we have alcohol drinkers, even though not so many, but surprisingly we have a homemade traditional alcohol drinking, and some claim that the concentration of alcohol can reach up to 70%, so it is very high and surprising. So for those reasons, Indonesian people have been exposed to the major risk factor associated with oral cancer. But nevertheless, oral cancer and oral pre-malignant or pre-cancer disorders and associated risk factors are not unknown yet in Indonesia. Yes, we have several research in small regional areas about prevalence of oral cancer or risk factors, but we don't have a nationwide oral cancer screening yet. So it does not represent the general Indonesian population. So there is no real data about oral cancer and oral pre-cancer in Indonesia. And another reason is that almost half of patients with oral cancer experience diagnostic delay, and over 50% patients seek treatment with advanced stage of disease. So here we are talking about the same cancer. So similar cancer with breast cancer, with cervical cancer. So these cancer are life-threatening diseases with different progressivity or severity in the nature. But the thing is that this is the same life cancer threatening disease. So this paper, I cited, this is a really good paper written by my friend from Malaysia, Professor Cheong, in 2017. So she made a research with the source from GloboCan. GloboCan is global oral cancer data made by WHO. And you can see here, Indonesia, yes, we have active cancer registry, but there is no real-time data online and not accessible. So to summarize, there is no data about oral cancer. There is no real data about oral cancer and oral precancer for Indonesian with a huge population. So why the prevalence of oral cancer and oral precancer or oral pre-malignant disorder is unknown in Indonesia? So I think because first, the term of oral cancer has not widely known by Indonesian people, and we have a weak recording cases problem. Not only oral cancer, but in this case, we don't have a real data, recorded data or case about oral cancer. And then the second, dentists and other health professionals are not capable in doing oral cancer screening. So dentists and other health profession have the pivotal role in recognizing oral cancer early, so then it can be treated early. It will lead to the prognosis of the treatment. And then the third is lack of government attention to oral cancer, either for program of oral cancer awareness or the research focusing oral cancer. So I think it is because due to the unknown data, but again, we have to start at some point, we have to start, because if we look at the risk factors that associated with oral cancer that have been exposed to Indonesian people, it's kind of like a ticking bomb in the future, and we will have a lot of oral cancer cases in the future, and it will lead to a lot of requirement of funding to treat, to facilitate for the manager for managing oral cancer in the future. Not only talking about morbidity and mortality and the hardship that Indonesian people will be facing. So this talk, this lecture will be based on my research, particularly that I did in my PhD, because I need to talk with evidence to bring this up, that oral cancer in Indonesia need a special treatment. We need to focus on that as soon as possible. So we did multi-factored study aimed to get pivotal information of oral pre-malignant disorders or oral precancer and oral cancer and associated risk factors in Indonesia, because the associated risk factors of oral cancer in every country will be different. So for example, in Australia, the major risk factors are HPV, human papillomavirus, and also alcohol drinking. But in Indonesia could be different. So that's why I wanted to know what is the risk factors of Indonesian people. And also we did the laboratory study to investigate various Indonesian beta-quid component to see whether the Indonesian beta-quid or Sari package from Indonesia containing carcinogenic, and then how it affects on oral mucosal cells such as keratinocyte or fibroblasts. So this is the methodology of my research. And I'd like to begin with oral premalignant disorder screening among Indonesian, the prevalence and risk factors. So if you see in the background, you see beautiful view. So you can see the land, the uphill land across that. The land name is Doom Island. I took the picture when we were about to cross this big river using this wooden boat. This remote area located in West Papua in Sorong. So I had a tremendous experience working together with West Papua people and also with local dentists there. Right, so these are the 5 selected provinces that I collected data. So this is an Indonesian map. So I collected data from Banda Aceh, Jakarta, West Java, West Kalimantan, and West Papua. So altogether, I collected data from 16 health community services, 1 dental hospital, and 3 selected villages. So it was a cross-sectional study based on questionnaire and oral examination. And the questionnaire included socio-demographic factors, oral hygiene practices, diet, risk factors, together with frequency and duration of consumption, socioeconomic status, and ethnicity to see the correlation with the oral cancer and oral premalignant disorders. And also afterwards, we screen people in 5 different provinces to see whether there is oral premalignant disorders or oral cancer in the survey. So this is the picture when we did oral cancer screening in 5 different provinces. I worked together with local dentists in that 5 provinces that I trained before we do screening in the on the field. So these are the OPMD and oral cancer cases found in the survey. Okay, so the number of people being screened was 973 people. The highest number came from West Java, and then followed by Banda Aceh, West Papua, Jakarta, and West Kalimantan. So if you see here in the chart that we found the highest oral premalignant disorder in people living in West Papua. So this is associated with the betel-quid chewing or arecanut chewing or menyeri. And then the second highest number found in West Java, and then in Banda Aceh and West Kalimantan, and the least number found in Jakarta. So this is the key point result for the first study, that we found 14.3% had oral premalignant disorders. It is an underestimated high number prevalence of oral premalignant disorders. So compared to the research done in Taiwan, in Guam, even the OPMD found was less than 10%. So we had this quite huge number of prevalence of OPMD in Indonesia. And 1.6% of respondents had oral cancer already diagnosed on examination. And 29% of respondents had some knowledge of oral cancer. And unfortunately, 17.8%, only 17.8% get the knowledge from dentists, and only 12.2% they said get from government. So let's move to the second study. The second study is about Indonesian dentists' knowledge in risk factors of oral cancer and in performing COE or conventional oral examination to do oral cancer screening. Why this is important? Because dentists and healthcare profession have the pivotal role in the front line to recognize oral cancer early by doing a proper oral cancer screening. So this is the picture. I educated, or I gave training to local dentists from 5 different provinces. And the number of dentists in the survey was 177. And the key point result that we found, most of dentists in Indonesia appear not to have adequate knowledge of oral cancer risk factors, as well as inadequate awareness and confidence in performing oral cancer screening as a complete examination that should be inseparable from their routine oral examination. But this situation is not only happening in Indonesia, it's also happening in the world, globally in the world. That's why the incidence of oral cancer is continued to rise. When we see the statistic, the other cancer, other type of cancer, it's getting slightly decreased, but oral cancer is continuing to rise, probably because of one of the reasons, because of the the healthcare professional cannot recognize the oral cancer early. So the second is oral cancer training could positively increase their knowledge and confidence of early screening. And also the survey could also identify the most likely obstacle related to why GDP tend to perform incomplete oral cancer screening and what specific step that dentists tended to avoid. And also it is important to approach Indonesian government to have the strategy to prevent oral cancer should also establish by creating national oral cancer programs. So then we can give a massive education to Indonesian people by creating a national oral cancer program. And the current oral cancer hands-on training could possibly be used as a training models to improve Indonesian dentist awareness of oral cancer. So I just want to bring a little bit result from the second study that 92.7% the dentists in the survey say that the oral cancer training at dental school is insufficient. So then we need to change that. Because of that, leading to the dentist not educating risk factors to their patient, and also leading to not performing screening in high-risk patient, and also not leading to also not complete to do complete examination. So I think this situation needs to change at some point. Right. So the next study is a laboratory study investigated better-quid components from four different regions from Indonesia using liquid chromatography mass spectrometry, and also to see a total phenolic content and antioxidant activities. So for this research, we have published one paper in Nature by scientific report. The title is Distinct Phenolic Alkaloid and Antioxidant Profile in Better-quids from four regions of Indonesia. I provided the link to that paper if you would like to learn more about that. And also we've already published just recently the second paper related to our study about better-quids in biomolecules. And I also provided the link if you'd like to learn more about that. Okay, so we imported Indonesian better-quid from four different regions, which was from Banda Aceh, North Sumatra, West Kalimantan, and West Papua. So as we know that better-quid package or menyiri, paket menyiri in Indonesia, so it contains different components. So some people like to put tobacco, clove, or any other spices, but the main similar content is areca nut, betel leaf. This is the areca nut, and then betel leaf, and also slake lime. Slake lime is the white powder to make the taste become stronger and make the combo become red, right? So we identified individually the areca nut, betel leaf, betel fruit. So betel fruit is coming from the same tree with betel leaf, from Piper betel, but from different branch. And betel fruit only being used by people living in West Papua. And then areca husk is the outer layer of areca nut. So some people like to peel off the husk, but some of the people like in West Papua, they like to include the husk into the mixture. So beside identifying individually, we also wanted to identify how the constituent, when it is being mixed into the mixture, like picture in the below. So as you can see here, only people from West Papua like to use betel fruits, but people from West Kalimantan, North Sumatra, and Banda Aceh, they like to use betel leaf and then put all the ingredients onto it and read it out before they chew and put it somewhere in the mouth. And if you see here that there is a different color of areca nuts, so people in West Kalimantan and West Papua tend to chew the immature or unripe type of areca nut. We can see from the green color of areca nut, but people from North Sumatra and Banda Aceh preferably to chew the ripe type or the mature type of areca nut. We can see from the yellow color of areca nut. So this is the result from our study. As you can see, this is the heat map, and on the right side is the constituent that were successfully identified using liquid chromatography mass spectrometry, and then below is the name of sample from different region. So as you can see here, West Papua areca nut and West Papua betel mixture has the highest concentration of catechin. So the red color show the highest concentration and the blue color show the least concentration of constituent. And West Papua areca nut and West Papua betel mixture also has the highest concentration of arecolin. So arecolin is one of alkaloid that can lead to the development of oral submucous fibrosis. Oral submucous fibrosis is one of oral precancer or oral pre-malignant disorders. So that's why in the survey, we can see the result that people living in West Papua has the highest number of having oral pre-malignant disorders compared to people living in other region. It is strongly associated with the betel chewing habits. Right, so the key point result for this study that betel compounds have distinct chemical features that are mixture and region specific. So, so different region, different mixture, so the chemical feature will be different. And then the ripeness degree of areca nut distinct the amount of both polyphenols and arecolin. The unripe areca nut contain a higher concentration of polyphenols and arecolin compared to the ripe areca nut. So we suggest that consume the ripe areca nut could lower the potential in developing oral submucous fibrosis or oral pre-malignant disorders type of OSMF. Why we suggest this to do harm minimization of betel, because at this stage it is almost impossible to ban the habits because it is already been strongly part of the culture. So at the very least, we can suggest how to harm minimize the betel using by suggesting consuming ripe type areca nut rather than the unripe. And then betel husk contain the arecolin. So betel husk is the outer layer of areca nut. So it also contain arecolin, the alkaloid one, which can lead to our oral submucous fibrosis. So then we also suggest not to include the husk. So it is better to peel off the husk and just eat the areca nut. So this is the result and the suggestion that we can offer from this research. So the next research is about metabolomic profile of Indonesian betel using gas chromatography mass spectrometry, because using LCMS, we didn't successful to identify other 3 alkaloid. So then we moved to use this GCMS. And then with this method, we successfully can identify 3 types of alkaloid. And then we also successfully identified saffrol from the fruit, betel fruit, because and saffrol is already revealed can cause cytotoxics to the cells. So again, the betel fruit is coming from West Papua, not betel leaf. So betel leaf actually has the chemoprotective role biologically. So again, this is the heat map. I'm sorry if it is too small, I think, but I would like to show you that we can identify saffrol, which can cause cytotoxic to the cell, and we found saffrol mostly from West Papua betel fruit. And then the last study that we did cell cytotoxicity effect on tissue culture, we wanted to make sure that Indonesian betel-quid can initiate the development of oral cancer. So then we made an extract of those betel-quid from 4 different regions and exposed it to oral mucosal cells, to keratinocyte and oral fibroblasts. So the result were that all the betel-quid extract from Indonesia can exhibit its cell cytotoxicity effect on oral keratinocyte, but not to oral fibroblasts, especially extract from West Papua arecanut and also from betel fruit from West Papua. So this is the key finding of all study, that we found the prevalence of oral premalignant disorders underestimatedly high. It was 14.3%. And the risk factors of associated with oral cancer and oral premalignant disorders for Indonesian people are smoking, betel-quid chewing, and alcohol drinking. And dentist has a pivotal role in oral cancer screening as a frontline to recognize oral cancer early, yet they have inadequate knowledge and also inadequate awareness and skill in recognizing oral cancer. And then betel-quid components, the different composition of betel-quid correlated with the number of the rate of oral premalignant disorder in different regions. And betel-quid's profile, it has antioxidant and also pro-oxidant, and how the cytotoxic effect of betel-quid, showing different composition of betel-quid had a distinctive cytotoxicity profile in stromal and epithelial cell of oral cavity. So what is the best strategy to avoid diagnostic delay of oral cancer? So first of all, that I've already mentioned, the problem in managing oral cancer is not only related to the rising of its incidence year by year. So the greater challenge is that oral cancer are not detected early enough for successful treatment of cancer. And the most effective means of reducing mortality of oral cancer by preventing late stage of oral cancer. This could happen by increasing awareness among the population, Indonesian population, and healthcare providers, specifically the dentists. Yeah. And patient knowledge of oral cancer is quite important as well. So we need to educate the people, the patient in Indonesia. So patients need to get adequate information about what is the risk factors can cause oral cancer, especially from dental practitioner, because I think people or the patient will trust the dentist when they educate the patient. And also according to this survey, we found that the respondents who have a good knowledge about oral cancer has less risk of having oral premalignant disorders and oral cancer compared to respondents who do not have the knowledge about oral cancer. And then again, however, our study surprisingly revealed high rates of dentists admitted to skip educating patients of oral cancer risk factors, and dentists neglecting to explain oral cancer risk factors to patients in all selected regions. And this could have a big impact on oral cancer in Indonesia. And people will be unaware of the cause of oral cancer and keep living in the carcinogenic environment, creating many further cancer cases in the future. And then another strategy is to improve dental health system in Indonesia. So in general, at national level, the ratio of Indonesian dentist specialists was only 0.3. So it means 3 dental specialists treating 10,000 population. Hence, the government need to also improve dental health system, in particular, the number of human resources. And then also we need to prioritize the dentist in community service in puskesmas, because the dentists who work at community service as a frontline in oral cancer screening program. So the dentists who work in the health community services tend to treat even more than 50 patients in a day. They don't have time to educate the patient about oral cancer. They don't have time to do oral cancer screening properly because they have to do it by themselves. So this should be changed. And if they are well aware about educating people about oral cancer at the very first level, and they can do a proper referral, then they can save other people's life. So if they make this oral cancer early screening as inseparable part of the dental routine examination, actually it only took 2 minutes to screen oral cancer, and it is not painful for the patient, and it's very easy. So then if they can recognize the suspicious lesion at early stage, early enough, then do the referral, we can stop that that situation or that lesion in the mouth transform into malignancy. So that means that we can save people's life by doing screening for 2 minutes. So this is the thing that we also need to work on. And then to work on by continuing oral cancer training to the dentist, because dentists should always remain alert of early signs and symptoms of oral cancer by properly recognizing and distinguishing oral premalignant disorders that appeared in oral cavity. And it will be difficult for dentists to decide whether to refer or just neglect if the dentists have inadequate oral cancer and oral premalignant disorder knowledge. So as a conclusion that it is important, firstly, that it is important to know the real oral cancer and precancer cases in Indonesia. So I think it will be wonderful, it will be great if we can work together with Indonesian government to do oral cancer screening nationwide. India and Taiwan, they have started that oral cancer screening more than 10 years ago, and they did screening in more than 5 million people to see, to represent the general population of their general population. And Indonesia has to start that. And then also it is important to, again, approach Indonesian government to put the strategy to prevent oral cancer in Indonesia should also be established by creating a national oral cancer program. Because oral cancer is the same or similar with other cancer. To beat cancer is to prevent it. So the best management of beating this disease is to prevent by recognizing early. So in breast cancer, we have mammogram. In cervical cancer, we have a pap smear to recognize early symptoms. So in oral cancer, actually, we have the type of oral cancer early screening, but then again, the dentists need to be knowledgeable and skillful of recognizing oral cancer early, and the people or the population, the people also need to know this is important to check, to get them checked regularly about oral cancer lesion early or oral premalignant disorders. And the third, it is important to educate people in communities and schools level for oral cancer awareness. So the younger age we can educate, the better the result will be. I think the most challenging thing for now is that to change the mindset, especially for better quit chewing habit, which is already part of culture. When I went to West Papua, they started to chew better quid as young as 5 years old, and they cannot start the day without chewing better quid. So you can imagine how many people being exposed with that carcinogenic substance. And it is not easy to change their mindset to stop that habit. So then probably the situation will change in the next 10 years, 15 years, or 20 years later in the next generation. But at some point, we have to start to educate the people about the dangers of that habit. And then the next thing is to improve national curriculum on oral cancer learning, so dentists could have sufficient knowledge and confidence of oral cancer before their graduation. Right, I think that's the last slide. This is, again, thank you for your attention. This is me and my colleagues that I've been collaborating with for oral cancer research. Professor Michael McCullough, Professor Nicola Chiro, and Dr. Pang Zenzan from Melbourne University. But I'm really open to work together with other people for oral cancer to prevent oral cancer globally, not only in Australia or Indonesia, but also all over the world. All right, I think this is really the last slide. So thank you very much for your attention. I will hand over to Kate.
Fantastic. Thank you so much for that one, Elizabeth. That was a really engaging and interesting presentation. I'm sure those in the audience seem as well. So we have our first question here. So what do you propose on how we do the general screening for oral cancer, and how do we crowdsource the data from the general screening? So a reminder as well to everyone in the audience to pop any questions you have for Dr. Fitriani in the chat as well. So question 1, there we go.
Yeah, sorry, Kate, can you repeat again the question?
Yeah, so the question is, what do you propose on how do we do the general screening for oral cancer, and how do we crowdsource the data from this for the general screening?
Yes, thank you. So as we know, that Indonesia has a huge number of population. So the strategy should, we should work together with dentists in who work in community services in puskesmas. We call it puskesmas in Indonesia. So we can do a national screening by working together with them. And obviously we need a good collaboration with Indonesian government to make it happen, because we need to also choose the representative region for doing this screening objectively. But looking at the huge number of Indonesia, 280 million population, then we need to include a lot of health community services, and to reach the significant statistical number to represent general Indonesian population. So I think first thing is to work together with health community services, and I think the Indonesian Health Ministry can generate that. And in Indonesia, we have oral medicine specialists who are expertise in doing oral cancer screening. So we can also get them included into the program, because obviously we cannot work in isolation. I cannot work by myself, or only me and 5 other friends in Indonesia who is oral medicine specialist, because we are going to do a nationwide screening. Then we need to include a lot of people to work together on that. So after we do the oral cancer screening together, then we can gather the data, and also we can put all the data and can analyze statistically. But looking at that, a lot of logistic things that we have to prepare, but because this is very important, I think it is very it is really important to start that, because Indonesia left behind 10-20% compared to India, to Taiwan, which they have the same situation with Indonesia in terms of oral cancer risk factors. And also, as we know that tobacco cigarette in Indonesia is very cheap, and 1/3 of Indonesian population are smokers. So we can imagine that how many oral premalignant disorder, oral cancer, can potentially be emerge in the future, or already emerge now, but because of there is no data about that, we do not recognize that. So I think this is very important. And the other thing is that once we have collected the real data about oral cancer and oral premalignant disorders, it will lead to another strategy about oral cancer awareness program to educate people, community, a student at schools, and as well as government can pick up another strategy to how to treat this disease in the regional level, because the most suffering people of oral cancer is the people who live remotely in remote area, for example, in West Papua or Papua, in West Kalimantan, because we have lack of sources and facilities. So we can just say, if you got oral cancer, then you just leave it until to die, let them die. I went to West Papua, even there is no specialist who can take care of this oral cancer, which is very common in the remote areas. So then it is very wise at this stage, looking at a lot of problems, multi-factors related with oral cancer in Indonesia, that we have to start to educate people and to do oral cancer screening to prevent this oral cancer emerging in the future, while also to put some strategy to manage the current cancer that can be found in the field. Because I've been working together with local dentists from 5 provinces that I train, and they still keep sending me some cases about oral cancer, and the main problem is that they cannot go anywhere to get the treatment. So the people from West Papua want to get biopsy or want to get treatment, they have to fly to South Sumatra, Sulawesi, or from West Papua, West Kalimantan, they have to fly to Java Island. But again, they don't have money to do that. So then those people in the middle low socioeconomic status is the the most unfortunate related with this oral cancer situation, oral cancer disease. So I guess we need to open our eyes about this, and we have to do something at some point.
Yeah, thank you so much for that one, Elizabeth. So last year, you were one of 13 recipients of the prestigious Australia-Indonesia grants from the Australian Department of Foreign Affairs and Trade. I was wondering if you could tell us more about the research project you'll be working on within that grant and how it relates to your research presented today by bridging some of those training gaps that you highlighted during your presentation.
Yeah, I'm really happy to explain that grant. Thank you, Kate. So I get the grant from Australian DFAT, Department of Foreign and Trade, Australia, to educate dentists, 8 until 10 dentists in 8 until 10 provinces of Indonesia, and we are working on that. We are working to do a webinar and training, virtual training, especially to dentists who live in remote areas, and find how to manage if they found oral cancer. So how to help them to recognize oral cancer early, and how the best treatment to be given to the patient at the very least if they don't have enough facilities to treat the disease. Yeah, it's already started, and it will be ended by the end of this year. So hopefully there will be another dentists from 10 provinces will be capable to do oral cancer early screening properly.
Perfect. Thank you for that one. And you mentioned in your presentation that oral cancers is one of the few cancers that's increasing globally due to inadequate training and recognition of the cancer. So what do you think explains this lack of training and knowledge on oral cancer? I feel like in Australia, it's also still quite unknown, and there are some barriers to diagnosis here in Australia too.
Yeah. So actually, that's not only happening in Indonesia. I think it is happening globally in the world. So the dentists are lacking or inadequate to have inadequate knowledge and skill about oral cancer early screening. So the dentists tend to only see the tooth or the teeth. They want to drill the teeth, to fill in the cavity, or to extract or do some treatment or do some dental cosmetic, which is good. But dentists also need to know that they have to see the surrounding oral mucosa, because what is for to have a very beautiful teeth, but you have oral cancer in the mouth, so you cannot enjoy food or anything else. So then this is the thing that I am still working on, that to increase dentist awareness of doing screening as part of dental routine. So even though the patient want to have extraction or scaling, the dentist need to do oral cancer early screening for 2 minutes, which is very easy if they can provide a proper tools. And then afterwards, then dentists also need to educate the patient about these oral cancer risk factors and how to do referral as soon as possible. And also, yes, and also in Australia, I think this is not, yeah, we need to also educate dentists not only in Indonesia, but also this kind of awareness need to be placed or to be set up in Australia as well. Yep.
Thank you for that one. We have a question here from Irene Wong. So are you aware that there is an Australian company that has developed a device where you can screen cells orally and get an instant image of the healthiness of the cell?
Yes, I'm aware of that. So there is a file scope. So I also had a research about that device. That's an additional device. His name is Professor Kamil Farah, who does many research about that devices or other some screening device. But the thing is that the device is cannot tell the exact situation of the cannot tell the definite diagnosis. So the gold standard still biopsy to see whether it is oral cancer or a premalignant disorder. So the device is very handy to discriminate the area of biopsy, and also to make sure that this is a suspicious lesion that we need to focus on, and we need to get the biopsy from that. But using the additional devices only will not help the dentist. So there is a lot of research explaining that the dentist firstly need to be able to recognize the lesion clinically, so in the mouth, because the oral premalignant disorders or oral precancer can appear in the mouth with different color, usually white color or red color, white patch or red patch. And then if the dentist is able to recognize that early, then we use that device to more make discrimination to do a biopsy. Because only using that device without understanding how to distinguish the lesion clinically, it will cause another problem to have an overwhelmed referral, because not all the lesions are oral cancer, or not all the lesions are oral premalignant disorders. So then another strategy that the dentists need to be able to recognize that suspicious lesion in the mouth first, and then we can end up with the additional devices. So for example, there is a lot of white patches in the mouth. Even candidiasis or fungal infection in the mouth can be seen as a white patch, as a white lesion. But dentists should recognize between which one is candidiasis, which one is oral precancer. So that's the thing that can only be done clinically by visual palpation and by doing some technique clinically, but not using the device. But the device always be really helpful to discriminate the lesion. Yeah, hopefully I can answer the question from Irene.
Yeah, definitely. That was great. A reminder as well to anyone, if you have any questions, you can pop them in the Q&A. Did you find any kind of similarities or repetition in the cases of oral cancer in Indonesia? For example, were women more likely to have it? Were some regions more likely to have it? I know you mentioned West Papua as well.
Yes, that's a very good question, Kate, because if you read from a lot of journals, so most of people who have oral cancer or oral premalignant in India or in Taiwan, predominantly male. But when I did a survey, it was predominantly female. So I don't know, is it because I collected data in head community services, and at the time a lot of female more concerned about their oral health compared to male. So then I need to probably screen more into communities rather than healthcare facilities. So probably that. And then another thing is that it is really common that all over the world that male are smoking cigarette compared to compared to female. And also in West Papua, I don't know the ratio between male and female who chew better quit, but again, in my survey, we found that more female is predominant compared to male. So the number of oral premalignant disorders and oral cancer mostly found in female from my survey. So so that's the limitation of my study. So then to delete the bias of the study, we need to screen more population to understand more about the correlation of those factors, and then also the age related, and also gender related, socioeconomic status related, and also even ethnicity, because probably some of that doesn't necessarily mean that one ethnicity is really prone to have oral cancer, but probably because of the environment and the culture in that ethnicity have been using a better quit chewing, for example, better quit habit. So that things that I want to expand for the research to get better result representing Indonesian population. And to do that, we have to do a bigger research, a bigger population to understand more about Indonesian situation. Yeah.
Definitely. Thank you so much for those insights. It was a really interesting and fascinating presentation today. So thank you for presenting for our Indonesia in Focus academic seminar series, Elizabeth. And thank you to our audience for tuning in and all of your questions. So next week, we have our 4th seminar series on democracy regression and environmental politics in Indonesia with Associate Professor Dirk Thomsa. Please follow us on Twitter at Trobe Asia or join our mailing list to find out more details for online events and Trobe Asia publications. Thank you so much again, Dr. Elizabeth, for your fantastic
likewise. Thank you so much, Kate, Daira, and also Matt. Thank you.
No worries. Thank you so much.
For our audience as well.
All good. Enjoy the rest of your days, everyone, and we'll see you next time.
See you. Thank you.
All good.